Guys, you all know me. I'm Dr. Zaib Qureshi. So I welcome all of you on behalf of MedExam Expert on this, the webinar on the labor ward prioritization. So today we are going to cover this important topic. And before that, I'm trying to give you an overview about the labor and the delivery module as well. So this is how we are going to start our, the session is, the agenda is. So first, I will try to give you an overview of labor ward. And then we are going to solve two questions. Okay, one is going to be on the labor ward prioritization, and the other is also related to the labor and delivery, but not the prioritization itself. But yes, that is going to be an interesting question. There is okay. So the hang in there. Just volunteer yourself if you really want to participate with me, and that is going to be fun. All right. So let's get started on this labor ward. Okay. So for the labor and delivery module, we all know that we have got the five domains. Yeah. So we have got the information gathering. So while we talk about the information gathering, so of course we are going to the ask the couple of things which are needed for our the management, because we are in labor and delivery. So of course we need to understand that what are going to be the relevant information that may influence intrapartum care, including the partograph and the CTG. So don't ever hesitate if you need any further the requirement, if you need any further information, even in the labor board as well. So remember, when a woman is laboring and you are taking the handover, okay, from the previous team, so of course you need further information that where this patient is now at the moment, what is her current Bishop score, I mean, how far is she how far is she in her labor, and apart from that, of course, does she have any kind of risk factors or no, which is going to influence your outcome. So you have to understand this thing that you just not need to the read the labor board, but of course you have to pick the important points what are going to be integral in your management. Okay, so CTG, and the in terms of investigation, so yes, you need to the ask for certain investigations which are very much important for your management part. Then communication with patients and families, able to ensure that the patient and the family are well informed about the course of the labor and any interventions including benefits and risks has been instituted. So having said that, it means that this is going to be where because I'm talking as a whole for the labor and delivery. So of course, for example, if a woman is here who wants to know about her birth plan, she has her own birth plan, and now you have to counsel her regarding her birth plan, which one is going to be the best for her. So always remember, we as a doctor, we know that what is best for the patient, but patient doesn't know. Patient has her own options. So it's always a good idea that if a patient comes to you with the the that okay, the question is that she wants to discuss her birthing options, so it's always a good idea that you can always say that, hey Julie, I can understand that you are here to discuss about your birth plan. So have you got your own birth plan, or have you thought that how and when you are going to give birth? Okay, so yeah, always inquire about birth plan. It always gives the positive impact on the role player as well. All right, and side by side, of course, you are being judged by the examiner too. Okay, so remember that you have to give the kind of impact in which role player is getting satisfied, as well as the examiner is getting his or her desired the answers from you. Then comes the communication with colleagues. So always remember that you have to be able to know when to involve your colleagues, be it seniors and the juniors and from the other specialities as well. You need to be able to prioritize cases on the labor ward, including when you are going to delegate the task. You have to be able to teach other procedures like instrumental deliveries. And this is going to be in terms of teaching as well. Repair of episiotomy, perineal shears, breech deliveries, cesarean section, etc., etc. You need to be able to manage emergencies such as shoulder dystocia, cord collapse, maternal collapse, eclampsia, and be able to conduct twin vaginal delivery and manage a retained placenta as well. So, I mean, in toto, what I can, emphasize on this that a good candidate, because you are, the by, the ST, the guide, you are ST4 or ST5, who is going to become ST6 sooner or later. Okay. So definitely college wants you to, the prioritize your labor ward. College wants you to know that how you are going to reach to your the juniors, how you are going to teach them. So of course there is a hierarchy, right? So every senior has juniors, and junior has the most junior as well. So this way the hierarchy works. So definitely, if you are working as a, the team lead, so of course you have to, the allocate tasks to your junior, then you have to take your feedback, then you have to ask them that, okay, I mean, how do you find my teaching? For example, how do you find, this station? Do you think I need to improve on something? Do you think that, I have, the answered your all queries? So communication with colleagues is something like that. In terms of another thing that, you need to understand what are your boundaries. Okay. What are your, you can say the skills where you have to stop, where you have to seek the senior input. Of course, the team lead will always have the senior as well. Okay. So ST3, ST4 will have ST5, ST6, the specialist registrar, and then of course the consultant as well. So you need to know that where you are going to involve your consultant. So don't forget, even in labor board, because generally, what I have scanned through, all these years, that, the RCOG will definitely give you on the labor board that, okay, so for this, like, I mean, we all do in our respective hospitals, right? So we do have immediate consultant, then we do have registrars, then we do have team lead, then we do have juniors, and the most junior, the candidates as well. Then when we take over, so of course we are going to allocate that, okay, the junior most one, okay, so you have to go, because we have to allocate them according to their, the kind of signed off procedures. For example, if one is good in doing, the bloods, so of course we are going to ask her to do bloods. We are not going to ask her to do the cesarean section right away. Okay. So cesarean section, the complicated cesarean section, simple cesarean section, and, the emergencies, while it comes for emergencies, so remember, emergencies are going to be dealt by the whole team. It is not going to be an individual task. But yes, as a team lead, you need to know that where are you going to allocate your team, where are you going to assign them, okay, according to their own potential, according to their own, the capabilities. So of course, if one doesn't know that how to do the bloods, if you are going to ask that, hey, can you go and, take the bloods? So of course, he or she cannot take bloods. So certainly, you need to be sure of that, what are the duties of all, the trainees and the candidates. At the same time, this is going to be overlapped with patient safety as well. So like I said earlier, that if you don't know that, how you are going to involve, any of the trainee, any of your junior or senior, so you are jeopardizing the patient's health, you are jeopardizing patient life. So you need to understand that, where you are going to, the put this, the important domain. So always remember, my dear all, patient safety is going to be an integral part of every module there is. So patient safety is going to be checked. Okay. Patient safety will be there in almost all modules. Okay. Then in terms of labor and delivery per se, you need to able to demonstrate and understand of all aspects of patient safety in labor, where she is going to, go for the labor. We all know that we have got, the 3 units for the delivery, right? So we have got, the standalone low risk midwifery unit. We do have alongside or the consultant-led unit as well. So you need to understand appropriate analgesia, fluid balance, fetal health, CTG. Then you need to understand that where you are going to involve, the pediatrician. Okay. In terms of applied clinical knowledge, it is going to be the same, that where are you going to involve your protocols, your guidelines, your evidences. Then, you have to make decisions about care of the patients as well. Okay. So you need to know that, how you are going to apply, the each and every knowledge. Okay. So management of delivery, technical skills, how you are going to deal with the multiple pregnancies, preterm birth, breech presentation, and shoulder dystocia. When it comes to the labor board, so of course, in all labor board, there are going to be, the 1 or 2 urgent cases. Urgent cases mean where you need urgent attention. So what is your aim? You are going to quickly, go through the complete labor board which has been given to you. Doesn't matter if you have, the 5 rooms, doesn't matter if you have 6, 8 or 10 rooms. Okay. So remember that you have to have a, the quick overview. And remember, you just have 10 minutes time as well. You have to utilize that 10 minutes. Okay. So of course, 10 minutes plus 2, you can get, the 12 minutes, or, the 2 minutes for the reading time, and another 1 or 2 minutes you can take. So you need to go room by room. You need to understand what patient has been presenting with, Has her oxytocin been started or no? Her membranes are intact or no? Epidural has been given or no? Does she have any kind of other risk factors or no? And who is currently taking care of her? Usually all low risk, the deliveries are going to be in the midwifery led care unit. I'm sure you all know, right? If a woman is, the taking labor in the alongside or in the, the consultant led care unit, so there is going to be, the something. So you need to understand that, okay, where you have to dig out, what you need to find out. Don't go necessarily that, okay, I will go for allergy check, I will go for her social habits, I will check that whether she's smoking or taking alcohol, and pardon me asking, the recreational drugs as well. Okay, so template is not going to be followed in this, the labor board. Always remember, you have been allocated only 10 minutes. All right, so you need to be quick, you need to judge quickly, you need to understand that you have to find out that, what are the patients involved, what are the, the patient, for example, one patient has been, the referred from midwifery care. So this needs to be undertaken, that okay, why has she been referred from midwifery? Because by rule we know that all low risk midwifery, all low risk labors are going to be in midwifery care. If a woman is coming from midwifery care unit, certainly there has to be something. So you need to dig out what exactly it is, why she has been referred, what is the, the her, the current history, current progress, what is the reason of referral. Okay, so for example, if there is any, the routine case that needs, the like, I mean, routine care, so okay, if there is semi urgent, so yes, you need to understand who you are going to allocate and why. If there is, the urgent case, then you need to understand that who are you going to allocate. So most of the time, you as an exam candidate are going to take, the most urgent one. Okay, you are going to take urgent one, you are going to involve your consultant, you are going to take, your, the other team members as well. So remember, the team has been given to you. That is the team you have to utilize on your labor board. Okay, so you are not going to go here and there, and trust me, the candidates who are just going to follow the, the set template, that okay, I'll go, I'll ask this. So I mean, hardly ever they can finish 4 or 5 rooms. So what if you come across with another emergency in room number 7 and emergency in room number 9 or 10? So what you will do? It means you are losing your station. So this gives you false perception while, the after coming from exam hall. So you say, hey, when you are discussing with your friends, and you say, yes, I had a very, the bombastic, the labor board. I said this, I said this, I said this. But who knows, what you did in your labor board? Because you just try to finish your 4 to 5 rooms on your set, the template, and on your set, the lines. Okay, so always remember, have a quick, the view over the labor board. Okay, have a quick, the check on the labor, and the do try to pick that which one is going to be the emergency, be it in the end, be it in the middle, or be it in the beginning of your the station. Okay, so labor board needs to, it's not hard, it's not like, I mean, a kind of, you can say, the difficult one. Okay, every exam will have labor board. So you need to understand that. Okay, and another thing I want to tell you is that this is not something which we are not, the familiar of, right? I'm sure we all are working, the OBG. Okay, some of us are consultant, independent consultant in our country, some of us are trainees, some of us are registrar or whatsoever. So this way or that way, directly or indirectly, we are doing this labor board every day, isn't it? Like, the if one the we are finishing our one shift, and usually, like in our country, we do have 24-hour shift, right? So from 9 o'clock today till 9 o'clock tomorrow morning. Okay, so for the 24 hours we are going to be responsible for, the every the team who are coming, the after 24 hours. So of course we have to give them, the complete over. So that is called handover, and that is going to be your labor board. For example, if we are leaving, the 3 and 4, the critical women, and if we are leaving, the 3 or 4 laboring women, so of course we have to tell them. So we have to tell them that, okay, this is 6 centimeter at the moment, and she's contracting well, and her CTG is good, and she's on syntocinon. So of course you are going to allocate one of your junior most. Okay, hey, go and, the find out what are her current, the findings. Then, for example, if there is any emergency, okay, so of course you are going to allocate accordingly, according to your, the team members. So this is not something out of the box. This is not something we are just learning for the first time. So don't get, the carried away if you see labor board. Okay, just imagine Just imagine that, okay, I am the doctor who is taking, the over from my previous, the colleagues. So this is how I'm going to deal with. So this is how you do, this is how we all do. I'm sure this is how we all do. All right. I hope it is clear. I hope I'm making sense. Is it clear, everyone? Any question? Mm-hmm. Clear, everyone? Okay, Tripti, very good. Okay. And rest of the guys, Samya, very good. Mm-hmm. Mariam, is it good? Nazia, Rukaiya, very good, very good. Okay, all right. So, I hope that you guys have enough, the information now that how we are going to do the labor board, all right? So, okay, very good, Shobna. So, who wants to volunteer and who wants to do labor board with me? Yeah, anyone?
Ma'am, can I?
Okay, no problem, no problem. I just need a candidate. Okay, okay. What exactly difference between labor board here in we did in FCPS and Royal College? Very good question. No difference, basically. Okay, no difference. I have done FCPS. I have done MRCOG as well. I practically did not find any of the difference basically in the labor board in FCPS and Royal College. Okay, the only difference was number of patients. Maybe in FCPS or the IMM we do get only 5 or 6 the patients. No, not assignments. Assigning is the all. In FCPS we call the PG1, R1, R2, R3 if I'm not wrong, resident 1, resident 2, and in MRCOG we do say the ST1, ST3, ST4 specialty training. So it's all like this. Okay, it's all like this. So don't just get the carried away. Like I said, this is not something out of the box. This is not something we are not familiar with. Okay, you just need to pick the important points and you just need to go along with that. Okay, Madiha? Clear, sweetheart? Okay, okay, very good. All right. So, okay, before we start, I have an announcement to make. That we are, the going, the on-site courses, and this is going to be in Islamabad. This is going to be on 23rd and 24th of December. So anybody who is interested, so I'll be there along with my other fellow colleagues. So we will have, the on-site circuit course, and this is going to be on for the 2 days. Okay. So anybody who is in Pakistan and interested can, contact me or mid exam expert team. And on the other hand, I am taking, the candidates for February exam and of course the May exam as well, and mocks too, because my mocks gets, they quickly filled, and in the end, I feel so bad that if I have to say no to anyone. Okay. Wow, Madiha, very good, very good. So it will be a good idea because the same mock is going to help you if you are going for, if anybody who is aiming for FCPS or IMM, and of course the MRCOG as well. Okay, so you guys can, the avail this chance. Oh yeah, sure, sure. Okay, okay. That's great. And yes, the one-to-one course mean that I'll be the only mentor and I'll be mentoring, the solely for my all candidates. I take very limited, the candidates. And still I do have, the 2 to 3 slots. And if anybody is interested, can get in touch with me or my team. Okay. Okay. All right. So the candidate who said wants to do the labor board. So this is for you, sweetheart. Okay.
Yes, ma'am.
Okay, so I will give you 3 minutes because I have to change the slides as well. Okay, so you can take
Okay.
3 minutes and it will be good for you to understand. So your time starts now. You will ask me to change the screen, all right?
Okay.
Shall I change slide?
Yes, ma'am.
Okay. Okay, start.
Okay, ma'am. Start.
Yes, please.
Hello, I'm Dr. Naz here, and an exam candidate. I'm here for a structure-based discussion. We can start. Okay, I have taken over with my team of this labor ward, and I will quickly review the labor ward chart one by one, and then prioritize myself and allocate my team members accordingly. I can change my priority. I can change my priority to if I see any urgent cases coming along. Okay. Okay. Room number 1. I can see that she's primary para, 38 weeks, and she's in epidural and syntesonon, and she had an LSCS yesterday. Ma'am, I have to reteach and everything.
I don't know. This is your task.
Okay.
You do, then I will give you feedback.
Okay. I can see she was re-brought to theater for re-stitching, and she lost blood 2.5. So I will ask my ST3 to go there and tell me her vitals and how is she doing. How is her drains and IO charting. So I would like to know her vitals, signs, drains, and IO charting, and how's she feeling now. What about the pervaginal bleeding and her pain? And uterus is contracted or not, because she's on syntesonon. Okay. And my on-call anesthetist, who is also there on call, will also be dealing with this patient. If anything goes wrong, they will call me. Okay.
So you will allocate anesthetist, yeah?
Anesthetist ST3. And my ST1 will go there to tell me what are the vitals and everything.
Okay.
Okay. Coming towards room number 2. As I can see, she's in second gravida, 41 weeks, and she was 3 a.m., 6 centimeter at 3 a.m. So I would like to know her pervaginal findings at this time, as it's 8 a.m. and her pervaginal finding is due. So I will send a midwife there to tell me what are the findings at this moment, and what are her CTG findings, and how she contracting, and what is the finding of the partogram. Okay. And she will ask if she's having any pain for epidural, if there's a need of epidural or not.
Okay.
Okay. Now coming towards room number 3, I can see she's primary para. Her gestation is only 20 weeks, and her membranes are intact, and she is here for termination of Edwards syndrome, and her misoprostol has started, but her contraction has stopped. So she is reverted for oxytocin. What do you mean by R/V?
Review for oxytocin.
Review for oxytocin. Okay. So this for this patient, I will go myself to see how is the patient going, feeling, and how are her contractions, and what's the finding of her pervaginal finding, to start syntocinon or not, and she's willing for the she has consented for starting oxytocin, and I will ask for epidural if she's coping up with the pain or not. If not, then epidural will be started, and then we will go for oxytocin.
All right.
Now, in room number 4, I can see para 5, 40 weeks plus, with clear liquor, and she's contracting, and she's in spontaneous labor, and she's 7 centimeter at this moment, but there is an urge to push. So I will send a midwife that how is she coping up with the pain, how is the vitals, how is her partogram, CTG, and how are her contractions, because it's only 7 centimeter, and why she's have an urge to push, what is the presentation of the baby. Then I will plan accordingly, according to the findings, and I will plan accordingly, but midwife can deal this patient till now. If anything will be urgent, she will call me.
Okay.
Okay. Now room number 5, I can see primary patient, 26 week. Her membranes are intact, but she's having tightening. That means she might be having preterm pain. She's having abdominal discomfort. CTG is normal. She's booked for an ultrasound scan. Okay. I will tell my ST1 to look at this patient. If everything's fine, how is the ultrasound finding now? If ultrasound is normal and there's no kind of any bleeding or any abruptio or anything else, then we will go for her preterm management. We will be giving her corticosteroids, and we will be admitting her and monitoring her for her preterm pains. But on ultrasound, they should be seen if there is any kind of bleeding or any kind of abnormality.
Okay.
So this can also be her findings will decide is she an urgent case or if she's a low risk case. After the findings, I will go myself if ultrasound findings are not normal or if there's any problem, then I will go there personally to see to rule out abruption. Okay. Room number 6, I can see she's second gravida, 40 weeks, and she's diabetic, insulin dependent for IOL. I will assign my one of my midwife, senior midwife there, and how she's how has induction now, has her induction been started or still she's waiting for the induction. And what is her sugar charting, how is her sugar charting and insulin going, as if her induction has started. So what are her Bishop scores, what is her partogram, and what is her CTG findings, and is she on continuous electronic monitoring or not? And then I will ask my midwife to tell me what are the current details. Okay. In room number 7, I can see a primary patient, 38 weeker. She's contracting and she was 4 centimeters at 4. And her vaginal examination was repeated at 7 a.m., but she's still 4 centimeters.
Mhm.
So this is a delayed labor. So I will again, I will go myself and again do her PV, her vaginal examination, to find out what are her findings, and will take her consent for amniotomy.
Mhm.
And then we will decide, and I will watch her bishop with CTG of the baby, and then decide accordingly. And we will, if there's no abnormality, then we will go for the amniotomy
Mhm.
to see the progress of labor. And after 2 hours, her vaginal examination will be repeated to see if she is progressing or not.
Mhm.
For this patient, I will inform my consultant, and I will inform my anesthetic, as she is having delayed progress in labor.
Okay.
Okay. In room number 8, there's a primary patient, 39-weeker. She has just delivered at 6 a.m. and she's awaiting for suture. I will assign my other midwife, who is expert in suturing episiotomy, and she will be suturing it. So and informing all her vitals and her current bleeding and
Mhm.
her urine output, and if she has started breastfeed or not, and how is her baby.
Mhm. Okay.
Okay. In room number 9, I can see para 3+1 41 weeker, and she is here for elective cesarean section, but now she's contracting. Okay. For this patient, I have to go myself to check. She's for elective section for which reason, and what are her findings per abdominally now. If she's contracting or her Bishop's has changed, and what
Mhm.
her indication for cesarean section. If
Mhm.
there's an indication for cesarean section which cannot be delivered vaginally, so we have to go for emergency cesarean section. So for
Mhm.
that, I have to inform my consultant, my anesthetist, as it can be in an emergency cesarean section. It can turn into an emergency cesarean section. But first, I have to go there, that why she's contracting, and what
Mhm.
are the vitals, and what are the partogram findings, what is the CTG, and are these preterm contractions, or she's developing something else like abruptio or anything. So I have to look myself to this patient
Mhm.
and inform my consultant and my anesthetist on
Mhm.
call. Okay.
Okay.
Uh, now room number 10, primary patient, 38 weeker, but blood stain liker, and she's having antepartum hemorrhage, contracting 2 in 10, and complaining of pain between contractions. Okay, this is also an urgent case, and it's looked like she's having abruptio. So I will be going to this patient too, but as I have to prioritize my patient. So first patient which I will be visiting will be this room number 10,
Mhm.
as she needs my urgent attention. And
Mhm.
I have to evaluate if she's having abruptio, or I will clinically examine her
Mhm.
abdomen, her contractions, her fetal heart, and her pulse, so that I can decide what she's having, and her ultrasound finding. And then I will urgently take her to her theater, and I will be informing my consultant now, and I will be calling my anesthetic, so that we can start, we can urgently shift her to the theater
Mhm.
if she's developing abruptio. And she will be most likely ending up in emergency LSCS.
Mhm.
Okay. First, my priority will be room number 10.
Mhm.
Then my priority will be room number 9.
Mhm.
Okay. And the after that, room number 7,
Mhm.
because her finding will also be evaluated after amniotomy 2 hours later. So that patient will also be on my list. After that, okay, after that, I will ask my midwife for the room number 4 findings, what has happened till now, and my ST3, who is the anesthetist, and my ST1 for room number 1.
Okay, fine.
Okay.
Okay, so this is how you took almost 13 minutes and few seconds. Okay, 13 and few minutes, few seconds. Well, I liked your approach that you went room by room, but again you did the same mistake. Okay, that you took a lot of time in the simple cases in which you didn't. So because while you were coming to this, I'm sure you must have had this this idea in your mind that there is emergency.
Yes.
So always remember, when you don't see any emergency from the room number 1 to room number 6 or 7, always be quick that you will be in emergency. Okay, so you can you see that in room number 10 you came across with this emergency. The same thing has happened in May exam, same thing has happened in November exam as well. Okay, this is how RCOG wants to judge that whether you can quickly take an overview of the labor board or no, whether because you took unnecessarily time over here, unnecessarily time over here, unnecessarily time over here. Okay, she is awaiting suturing, so simple say that she needs suturing, so I will send one of the nurse who can suture the episode. Simple. Then I will ask her to just inform me if any untoward the event happens. That's it. They don't want you to tell that whether she is breastfeeding, whether she is having the problem. But the thing is, whatever is given in front of you, that is your question, and you just have to deal with that. Okay, for example, if it was given she is unbooked, for example, it is unbooked and she came delivered. Okay, she came delivered and baby was born before arrival and she delivered at 6 a.m. and the midwife could not suture. Then you can say that okay, this might need the urgent intervention, because she has been delivered 6 a.m. and now it has been 2 a.m. The 2 hours has been elapsed. So I'll be concerned about this, whether she is bleeding at the moment or no. What are her, the observations at the moment? What about her baby? So I will send midwife coordinator or the senior midwife to go over there and just to see the patient's current condition. Okay. But if the question is given in front of you that she is awaiting suturing, okay, so your answer should be okay. So I will allocate one of the midwife who can suture episiotomy. Simple. Go ahead. Okay. Go ahead. All right, so let's take the questions one by one. I liked your approach, Nazia. It was not that bad. Okay, but the thing is, you need to be a little bit quick. Okay, you don't have to take much time. Like in this, the scenario, she is here for induction of labor only. Okay, so you don't need to waste a lot of time. That you can simply say that I will assess this patient after dealing with all emergency cases, because this seems to me the case which needs attention as well, because she is type 1 diabetes. So I will ask one of the midwife to start her on sliding scale if at all it is needed, because if she is on induction of labor, then we have to find out that what are her current the blood sugars and all. So I will send one of the midwife to check her record, to do her the examination, and inform me if there is any kind of concerning feature. Meanwhile, I will ask her to prepare the sliding scale and do the blood sugars and just tell me simply. Okay, so yes, induction of labor, because 8 o'clock usually patients get admitted early in the morning for the induction of labor, so this is not very unusual as well. Okay, the major part over here is that she is diabetic and she is type 1 diabetic. So yes, we need to know what are her current blood sugars and all. Okay, then for this case, misoprostol, and this patient is just the 20 weeks. Why would you go yourself? 20 weeks and the misoprostol for adverse syndrome, it means the congenital anomalies. Okay, she stopped contracting. Whether the baby has been expelled already. Okay, so you would send one of the midwife to just go and do the examination, just do the pervaginal examination, and just to check that whether the baby fetus has been expelled or no. Okay, if fetus has been expelled, then yes, that needs to be the scene, and then the wait for the placenta. Don't do unnecessary intervention. This is what we do. All right. And you can say that, okay, she is here for review for the oxytocin, but I would like to know that, why her, the syntocinon has been stopped. Okay, so this is important. So I think, you took little bit long in here,
Okay.
you took little bit long in here, you took little bit long in here. Okay, so what I feel is that, this was kind of, the unnecessary. And for this as well, she's here for elective cesarean section, and now she's contracting. Okay, so send somebody to assess. Simple. Okay. Don't say that, okay, that I will inform anesthetist, I will inform consultant. She might, yes, ultimately, she might need, this is an insection. For example, if she is, the previous three scar, then yes, I will send one of the midwife to take the detailed history, to take the record. Or if ST1 is free from, if you have allocated ST1 over here, then you can say that, okay, this needs that if ST1 is free from the room number 1, I will ask him to go there to room number 9 and take detailed history to look for any the risk factors, and to look for to take the detailed history, because if she is para 3 and she is here for elective cesarean section, previous cesarean section, so we need to know about the recent scan, because that is going to be the worrisome at the moment. Because what if she is
Yes.
having low lying placenta, what she is having, the placenta accurata, what she is having, the any morbidly adherent placenta. So I need to know. Just one moment, Adan is there. Okay, just 1 minute. Okay, so let's discuss again. Okay, so fine. Now you got the idea, Nazia, that where were you lacking? Okay, so always remember while you are dealing with the labor board and you haven't come across with the acute emergency. So always remember you will find it in the end of your labor board. Okay, in the end of your the rooms. So make sure that you are the dealing with all these cases so quickly. So your start should be very crisp. And while you are presenting, the any labor board, you will simply say that, okay, hello, I'm one of the exam candidate, and I have been given the opportunity to do with the labor board prioritization. So I'll be taking an aerial view to the labor board, and then I will prioritize. I will go room by room, but I may change the priority and the allocation if I come across with the emergency in the successive rooms. So my first room is, so this is how you are going to start. So at least the examiner will know that, okay, this particular candidate know how to deal with the emergency, how to go about the cases and all. So somebody has asked that, can we deal with the room end? So of course, if you are having the bleeding woman in the end, if you are seeing the cord prolapse in the end, if you are seeing shoulder dystocia in the end, that is going to be your most prior the case. So that only can happen if you will have the quick overview. If you will take a lot of time in dealing with all rest of the 9 rooms, so I'm sure you will run out of the time. Okay, so always remember you have just been given 10 minutes. In 10 minutes time you just need to quickly go through. Trust me, it will be very easy if you will not take the unnecessary time in your the cold cases, or you can say that non-urgent cases or the routine cases. It will never take any time. Always remember, in one labor board you will have 1 or 2 emergency topmost priority cases, then 2 or 3 semi-urgent, and then rest of them are going to be the routine cases. Like in this case, you can see that she has been delivered. She has been delivered yesterday afternoon. So yes, and today morning you are taking over. She has taken back to the theater for bleeding at 2 a.m. Okay, at midnight. Angle over soon and drain has been cited. Blood loss was to 2,500 mils. So she is on monitoring at the moment. So you will quickly send your anesthetist. You are not going to allocate your ST1 because you need your own the team members as well. So you can simply say that, okay, see, this patient seems to be the delivered and the reopening of the abdomen because of the PPH. So I can see that I can send one of my anesthetic colleague ST3 to go there and do the monitoring, and I will ask him to inform me if there is any untoward thing happens. Side by side, I will inform my consultant about this patient as well, that we have taken over for this patient. Then I will move to the room 2. I can see that she is para 2, she is 41, she is pouring clear liquor, and she's not on syntocinon, and she's not on any epidural as well. So I can see that she is in spontaneous labor. She was 6 centimeter at 3 a.m. So 3 a.m. she was 6 centimeter, and at the moment she is 8 o'clock. So I would like to know her current finding. I would like to know what her current Bishop score is, her current CTG finding as well. So I will send midwife coordinator to go there and just to reevaluate the patient and inform me that why this is happening, because this seems to be the prolonged first stage of the labor. So we might need to do the further intervention. But before that, I need proper the findings. So meanwhile, I will move to the next station and I will ask midwife to inform me. Then I can see that this is 20 weeks and she is primipara, and she has been for the termination of pregnancy for the congenital anomalies, and she has stopped contracting. So one of the midwife is taking care of her. So I can see that she is having the she might. So I will send one of the midwife to do the examination, per abdominal examination, per vaginal examination. If at all the contraction has been stopped, there is possibility that the fetus has been expelled. If fetus has been expelled, I will ask that look for the placenta as well, and don't do unnecessary intervention, and just check for the spontaneous expulsion of the placenta as well. Then after that, we will send, I will go and find out the record that whether we have to send this baby for the examination or no. Then I can see that in room number 4, she's grand multipara. She is 40 weeks and she's contracting spontaneous labor 7 centimeter at 8 o'clock. It means that right before my, the time while I took the over, and she has urge to push. So I will send senior midwife to go and just to find out that what is her current finding. Has she been on she hasn't been on syntocinon, why there is any urge to push. Then I will see that tell me about the Bishop score, especially her the presenting part. If the presenting part is high, so I will ask her to be there and look for the CTG as well, CTG pattern as well. Then I will ask her to inform me if there is any untoward situation. Plus, I will inform my consultant for this woman as well. She's primipara. She is having tightening loin pain and she is 26 weeks. And abdominal discomfort, CTG abnormal, booked for the ultrasound scan. Okay, this seems to me that loin pain is giving me hint that she may be having, any problem with the urinary tract, particularly the pyelonephritis. And because of the pyelonephritis, she might be going into the preterm birth. So I will allocate, the ST1 to take detailed history, to do the examination for abdominal examination, to look for any other concerning features as well. CTG is normal at the moment, and she is booked for the ultrasound scan. I will ask him to do the to look for the ultrasound scan and also send her MSU, send her full blood count just to see that whether she is having acute UTI or acute pyelonephritis or no. So I will send her, and if at all, she is a candidate of the preterm birth, then she will be managed on the lines of preterm birth according to the unit protocol. I will ask ST1 to do the complete examination and send the bloods, and I will ask him to inform me. Then I can see that she is, the para 1, 40 weeks, and she is diabetic, insulin dependent, and she is for induction of labor. So yes, I will ask one of the midwife to take the detailed history and to send me if there is any kind of risk factors involved apart from this diabetes, because then before induction of labor, we have to take consent, we have to start her own sliding scale as well. So yes, I need to involve my consultant in this case too. The primipara, she is 38 weeks, contracting 4 centimeter at 4 hours, and repeat vaginal examination at 7 hours, still 4 centimeters. So this seems to be the prolonged first stage as well. So it needs further examination. So I will go to this woman after dealing with all emergency cases. I will go and examine myself. And if there is a need for intervention, for example, that if we have to do the amniotomy and if we have to start the syntocinon, I will do it. I will inform my consultant, and then I will have a look at the CTG as well. And then I will see that if there is any concerning feature in the CTG, then the management is going to be on the basis of CTG. Room number 8, primipara, 39-year, delivered at 6 p.m. awaiting suturing. So I will send one of the midwife who can suture episiotomy. And the 9th case, I can see that she is para 3+1. She is for elective cesarean section. So I will ask one of the senior midwife to go and to find out in the record if there is any concerning feature. Because if she is para 3+1 and she is here for the elective cesarean section and because of the previous 3 scars, so this needs my urgent attention. So I will go to this woman myself later on. Meanwhile, I will be managing rest of the cases. I will ask her to give me, the detail, plus ask for the blood if it has been arranged. I would like to know her current ultrasound, her finding. If it is para 3 because of the previous scar, then I would like to know about her if there is any concerning feature with the placenta. If it is low-lying, if it is morbidly adherent, if it is placenta previa, accreta, or increta, perfita, or anything. So I would like to know about that. I will involve my consultant in this case as well, because if she is contracting, if she goes into labor, then yes, we will have to deliver it in emergency. Then in this, I can see that she is para 1, 38-year, blood-stained APH, contraction 2 in 1, and complaining of the pain. So this seems to me the abruption. So this needs my urgent attention. So I will ask one of the midwife to send our blood, to arrange the blood, inform blood bank. I will inform my anesthetist. I will make sure that, she is vitally stable. So I will ask one of the midwife to pass the double IV, catheterize her, and do the scan, because the scan, if it is necessary. On CTG, there is early deceleration on CTG. So I will do vaginal examination. I will check that whether there is feasibility for the vaginal delivery, then yes, she can be delivered vaginally. If she is para 1, then yes, I will involve my consultant, and then mode of the delivery will be decided on the basis of the examination finding. So my urgent priority is going to be the room number 1. Then this is going to be my top urgent priority. So I will do it myself. I will inform my consultant as well. Then I can see this, this para 3. This will be according to the, her history. If it is the only, the one cesarean section, then VBAC can also be there. Para 3, then yes, I need, the examination, and then I need, the ultrasound findings as well. So I will see this patient myself. Then this can be, this semi-urgent case, the DK, the type 1 diabetic. So yes, I will see this, the lady myself as well. Then I will look for this patient who is delivering, and the check progress. I will check the progress, presentation, and position, contraction. So senior midwife, and later on ST5, I will involve my consultant as well. Then rest, I can see that they are the routine cases and that can be managed. But yes, this is going to be my top urgent case, then semi-urgent, then this semi-urgent, then this semi-urgent. So this is how I'm going to manage my labor board. Okay, Nazia?
Yes, ma'am. Ma'am,
See,
one thing I wanted to ask
you don't have
in
to give complete, the kind of, the management in every case. Yes, please
okay.
ask.
In APH patient, can we do vaginal examination?
APH, she is having pain. So that makes, yes, why not? Abruption, we do vaginal examination.
Okay.
Because in abruption, this is a rule that, if there is a low risk case and if there is no other, the risk factor is present, then yes, amniotomy will reduce the, the uterine pressure, and the blood will irritate cervix, and the patient can dilate more and she can be delivered vaginally. If there is, no any risk factor, then if there is any risk factor involved, then yes, we have to deliver by cesarean section. Cesarean section will be always going to be accordingly, the gestational age, according to her observation, according to her vaginal examination and risk factor.
Okay.
Okay, good. Okay, clear everyone? Any questions? Yes, most urgent is in 10 room number 10. Most urgent case is in 10 room number 10. Okay. Very good, Amal. Very good, 50. Yes, you can start. If you picked it from the beginning that, okay, yes, my most urgent case, I can see that she is in room number 10. So this is going to be my topmost priority. Remember, what is your topmost priority? Where you have to save the life of the woman, save the life of the baby. Okay. So remember, emergency, urgent, the cases are going to be where you find out that if there is any shoulder dystocia, if there is any cord prolapse, if there is any bleeding woman, if there is any APH, if there is any PPH, okay? So those are going to be your top urgent cases. All right. If you feel that, the rest of them are, the kind of, the routine cases, so take them as routine. Okay. And allocation should be very, very crisp, and allocation should be very clear. Don't allocate your own fellow colleague in the beginning. Okay. Usually what I have seen so far in exams is that, usually monitoring cases are, there. If monitoring cases are there, involve your anesthetist. Okay. And plus, quickly go through and ask, and, the tell examiner that, okay, I will ask him, to monitor and inform me if any untoward situation, the happens, or if any untoward situation arrives. Okay. So this is how, it has to be. It's not like that, in 10 minutes time, you have to manage and you have to send her home like in your 10 minutes case. Okay. So remember, you just quickly have to go, okay, I will go to this, I will go to this, I will go to this, I will go to this. I will ask him to inform me. I will ask him to inform me. Okay. So this is how, the labor board prioritization needs to be done. I think this is what we do. Okay. So, this is how we need to do. Okay. So I'm sure we all do like this, that, if we have our, the immediate junior, so we will send her or him to the patient, which needs to be dealt early. And we usually tell him, that, okay, can you please, ask, tell me if there is any kind of complication. And usually it happens. Sometimes, we are taking over and any emergency arrives, so we have to run. We have to run towards that emergency. That is going to be, your emergency. How do we decide ST3, not ST2 to be that is your job, sweetheart. You need to understand that what are the responsibilities of ST3, what are the responsibilities of ST2. Okay. By the time you are in MRCOG part 3, you need to understand that, how does this training matrix works. And I think we have had, a previous station as well. You can go through on YouTube. Okay. I have had that, the, I think responsibility station as well. Okay. In first room, we had ST3 anesthetist. Okay, so anesthetist will always go where you think that that needs the HTU monitoring or ICU monitoring. Usually they keep the cases which are the bleeding, or which they have been kept for the monitoring. Okay. If you really think that epidural is going to change your outcome, then ask for epidural. Okay. Always remember, epidural is not the question. Okay. If you really think that epidural is going to change your outcome for the case, then yes, whichever you think. Though, I mean, exam is like, I mean, whatever you justify, whatever you can justify, that is your exam. If I don't mind if you want to keep this as a the room number one emergency. I don't mind if you want to the keep it as room number one. Okay, justify why you want it keep why do you want to keep it at room number one. If you are justifying, if your the approach is correct, you may the kind of justify this. But if you are failing to the diagnose this patient, it means you are failing a complete session. Okay, so usually this happens because I have been the examiner, and this and that, so I have had this opportunity to take the labor board. So this is what the candidates give feeling out of the labor board, that we have dealt 6 7 the rooms very well, but I could not find any emergency. So maybe you have missed rest of the rooms. Okay, you must have the heard from your fellow colleagues after exam as well, that many of the candidates say that yes, I have dealt all these cases very brilliantly, but I could not find any emergency, which is very unlikely according to me. Okay, which is very unlikely, because I'm sure college is not stupid. They really want to judge that how a candidate will respond if he or she is being placed in the the labor ward. Okay. Okay, good job. Good job, Nazia. Brilliant. Okay, not bad. Okay, it all needs the courage to come and to present in front of everyone. Secondly, yes, your approach was very good. Thirdly, you just need to be a little bit quick. You don't have to manage the case from head to toe, and then of course you are going to be short of time, and that is going to cause your station. Okay. Okay, brilliant, brilliant. Okay, so great job. Clear, everyone? I'm sure it is clear. Yeah, any question? Hmm? Okay, so I need another volunteer for another, the beautiful station. If anyone can come and, the present. Very good, Kanchan. Very good. Good to see you. Good to have you after a long time. I hope you're doing good. Hmm? All right. Okay, so who wants to present? Very good, Kanchan. Very good. All right, so nobody wants to present, so I will end this session. I don't mind if you don't want to learn. Okay, Tripti, very good. Okay, so
Hello,
Tripti,
ma'am.
hi, sweetheart, how are you?
Uh, Good, ma'am. Thank you, ma'am.
Okay, that's good. So I will give you, the 2 minutes. This is a very interesting case. Okay, so these days I can see that RCOG is changing some of the pattern of the exam as well. So this year in November exam, not in the labor board, but yes, in the gynae board, they had, the one referral and one, the OT list. So I think this is going to give you an idea of how you are going to perform. Okay, so take your 2 minutes time, sweetheart. I have another slide as well. Okay. I have next slide for, the how you are going to deal with every case. Okay.
Okay, ma'am. Okay, ma'am. Next slide, please, ma'am.
Okay.
Yes,
Yes, Tripti.
yes, ma'am.
Mm-hmm.
Shall I start,
Okay.
ma'am?
Yes, yes, please.
Mm. Hello, I'm Dr. Tripti, one of the exam candidates. I have read the instruction. I'm ready for the discussion.
Okay. For the
So,
each clinical scenario, you have to select the most appropriate pattern for the triage. Okay. How you are going to give your antenatal care. Okay. So take me through your management plan.
so case number one, she is 28 years, 8 weeks of gestation, a third pregnancy with one vaginal delivery, and the second was elective cesarean section for breast. So she is here to discuss about mode of delivery, and
Mhm.
so she will be under consultant lead care as in a tertiary unit, as she has previous cesarean section, and um, so she will have shared care between midwife and consultant basis at 12 weeks. And Tom, um,
So you mean
uh,
the answer is age? Yeah.
mm, uh, yes, ma'am.
Okay. Fine. Next question.
Next is Mrs. Havens. She is in her first pregnancy, and her she was last seen in early pregnancy assessment unit with a threatened miscarriage. She had a scan which confirmed that she had a viable monochorionic diamniotic twin pregnancy of 10 weeks of gestation.
Mhm.
So she will be under consultant lead care.
Mhm.
She will be in a consultant lead care. Uh, and she will have a 2 weekly scan, uh, a 4 weekly scan, a 2 weekly scan from 16 weeks of gestation, as she is having monochorionic diamniotic twin pregnancy.
Mhm. Okay.
And
Then
and next case is 32 years. She is in third pregnancy. Both her children were born by a normal vaginal delivery. But after each pregnancy, she suffered from postnatal depression. But she is no longer taking antidepressants, and although a little anxious, is coping well with her. So she will be. Uh, Ma'am, could you please on the next slide, please?
Mhm. Mhm.
Yeah. Um, so so she will be in a shared care between consultant and perinatal mental health. So my
Mhm.
answer will be F.
J.
F.
Okay.
Yes.
Fine.
F.
Mhm.
Consultant and perinatal mental health.
Okay. Next.
Mrs. Douglas, this is her third pregnancy. She has two children who were born normally, but now she is in a new relationship, and she is a smoker and has a BMI of 28. That means she is overweight, and she is a smoker. Mm, she will be under midwifery care and midwifery care.
She will be in midwifery care.
She will be in midwifery care, late care. Uh, at at 20 weeks and Tom.
At 20 weeks and
And Tom to rule out intrauterine growth restriction.
there is okay. Okay. So let's see. Not bad, not bad. So first case is she's 28 years old and currently 10 weeks of gestation in her third pregnancy. The first was a normal delivery and the second was an elective cesarean section for breech. She would like to discuss her vaginal delivery, okay? And her current is 10 weeks. So of course, we are going to have, the checkup at, the 10 weeks. And then of course, we are going to, 20 weeks and then, it is going to be the term. All right. So yes, your answer was correct for this. Okay. Then our next case was she's in her first pregnancy and last week seen in the early pregnancy assessment unit with a threatened miscarriage. She had a scan that confirmed a viable monochorionic diamniotic twin. So yes, you later picked that yes, she is monochorionic. So she needs the fortnightly scan from 16 weeks of gestation. So yes, it was correct as well. Then our third case was she's 32-year, third pregnancy. Both the children were born by the vaginal deliveries, but after each pregnancy, she suffered with postnatal depression. She is no longer taking antidepressants, and although a little anxious, but is coping well. So yes, parental mental health team. So this is how it can come. So yes, J. And then our last case was this is her third pregnancy. Her two children were born normally, but there is a new relationship. There is a smoker. She's a smoker and has a BMI of 28. So yes, she will be having, she seems to be the low risk. Yeah. So, the BMI is 28. She's a bit overweight and the smoker as well. Apart from that, there is no other risk factor. So two minor risk factors. So this way or that way, she can be delivered in the midwifery care unit. So midwifery led care throughout. So we will give her midwifery care led unit. Okay. So in a way, very good, Tripti. Very good. Okay. So remember, you have to justify your the station, and you have to tell that why I want to do that. Okay. And because I kept this station, because in recent exam, I'm sure you all know that in the I think day 2 or day 3 or day 4, there has been the two gynae cases. Okay, one was the theater list and the other was the triage, the kind of list, that where you are going to send this patient. Okay, who is going to see this patient, what is going to be your priority for this patient. Okay, so make sure that you are doing in the same the pathway. Okay, you are dealing with the same way, because be it the ops case or the gynae case, the theme is going to be same. Okay, it is not going to change. So always remember, you always need to justify. So it will look more beautiful that if you will say in the second case that I can see that she is having she has had the threatened she has had she has developed threatened miscarriage in the early pregnancy assessment unit earlier, and now she is monochorionic diamniotic twin pregnancy of 10 weeks of gestation. So that makes her a strong candidate for the the continuous monitoring, because keeping in view of that, she can be a candidate of twin to twin transfusion syndrome and the other complications particularly associated with the monochorionic twin pregnancies. So I would like to have her, the consultant-led care unit with 2 weekly scans from the 16 weeks of the gestation. So this is going to be my, this is going to be my management according to the Green Top guideline. So always remember that, examiners are going to be very happy that if you will say all these type of, the sentences that according to the guideline, according to the TOG article, according to the current evidence, according to this and according to that. Okay. So, in this structured discussion, there is always a room. There is always a room where you can speak a bit more, because there are, the chances that you may finish your, the station early, but yet on the other hand, you have got more room, more chance to, to gain more marks. Okay, so always remember that you are the managing each and every case. For example, if there is any triaging, if there is any the kind of thing that where you have to send this woman, okay, this way or that way, you have to be very careful about that. Okay, clear everyone? Any question? Any question with regard to your preparation? Anything whatsoever? Yeah.
Hello.
Hello. Yes. Who is this?
Hello. I'm Samya. Dr.
Yes.
Zaib, thank you very much. It was really nice and informative session.
You.
My question is that how much time does it take to prepare for the exam? And which you asked in the start. So what do you suggest? How much time we should give every day to prepare, and how to for example, this type of cases, how many in one day out of 14 module scenarios or stations, does it come once, or if the same like labor ward prioritization and this antenatal triage, both come in the same day, or
you cannot predict, sweetheart.
okay.
The thing is, the thing is, because labor board is an integral part of your labor and delivery module, right? So sometimes you can expect labor board, but trust me, none of the exam is complete without labor board, without gynae board. So you never know what you will get on your own day. Okay, so as exam candidate, you have to be prepared. You have to give your 100%. You don't need to leave any kind of loop. Okay, so at least you have to have an idea that how you are going to they come across with this, if at all you come across with these type of stations, so how you are going to start, how you are going to finish. Okay, how much portion of defaults? And no portion. Okay, no portion, because there is not like, the straight away they are going to give you the past, the paper, the past exam, the scenarios. They might change some of the the station, they might change situation, they might change the real exam, the scenario. Okay, the task can be different, your the scenario can be different, although because syllabus is same, syllabus cannot be changed. Okay, of course if labor board has to come, labor board will come, but the question will be changed. Okay, so don't ever think that you will get the same scenarios, and don't just try to the mug up all these the recall questions, and you are going to be like happy that yes I'm done with everything. Okay, yes, I don't know your name, so yes, you have to revise your the concerned Green Top guideline, concerned NICE guideline. Okay, everything. Always remember, because we do have two types of tasks. Yeah, we do have structured discussion task, and we do have simulated question task. So sometimes there can be the distribution. It can be 7+7, it can be 6+8, it can be 5+9 as well. So you never know what you will get. Okay, so remember that structured discussion task has equal importance. And for me as an exam candidate, because I have been through this exam twice, okay, so I know for me structured discussion has always been so challenging, because in structured discussion, because you never know what will come and what you are going to speak. So your applied clinical knowledge should be very thorough. You should be thorough with your all guidelines, concerned topics, okay, and concerned the TOG article. So of course, if there is the maternal medicine is a huge module. Okay, and from maternal medicine you can get any question out of anywhere, right? Asthma, you have asthma TOG article. You have inflammatory bowel disease TOG article. You have thyroid TOG article. You have skin diseases TOG article. So you never know what you will come, what you will get as an exam scenario. In terms of guidelines, so yes, you do have sickle cell disease, you have thalassemia, you do have malaria, you do have sepsis, you do have, the all, the important labor guidelines, right? Breech delivery and everything. So make sure that, you are well versed with all important stuff. So remember, obstetrical emergency should be on your tips. Maternal medicine, the important topics. Make your list, prioritize, okay? Prioritize your own stuff, all right? And then, of course, you are going to, to go about. Study plan, Samia, study plan is going to be accordingly, okay? Many people, they want to cover, the books, or they want to go module by module, okay? There is a group on the Telegram of the Med Exam Expert, MRCOG Part 3 guide, okay? And we have shared a comprehensive, the study plan over there. We have shared, the complete syllabus over there. Okay, for the part 3, you can download and you can, prepare from there. Even on the Facebook, I believe. Okay, on the Facebook as well. In the file section, if you will go, you will find, the comprehensive, the schedule for MRCOG part 3. On the other hand, for the books, I must say that, books are going to give you idea. Okay, books are going to give you the idea. Details of 2-day course. Yes, Madiha, my one of the team member will contact you. Anam, Muhira, if you guys are there, so please get in touch with Madiha. Okay, tell her about the course. For the books, okay, for the books we do have the couple of books, right? So we do have Oxford, the task book. It has almost 89 scenarios. We do have the Tony Hollingsworth book. It has 50 scenarios. I still remember. We do have, the Get Through book. In Get Through, we do have, the almost 14, 14, 28 and 6, 30, 34 stations. Okay. So we do have, the Lisa Joel. Yes, Lisa Joel. I love this book. So in Lisa Joel, you will get almost 14 and plus 4, 18 stations. So can you see that, you have got plenty of stations to practice. It means you are practicing all these stations. It means you are revising all these topics. So don't just, think of that you are going to get, all these kind of, the topics, all these questions. These are practice books. All right. Zayed, if I'm not wrong, one-to-one schedule. So yes, Muhira, if you are there, please get in touch with him, okay, or her. And, you guys can, get in touch with me as well, all right? On WhatsApp, on Telegram, on Facebook, I'm open, and, you guys can get in touch with me. Not only for the schedule, okay, for any kind of help, if you guys are facing any kind of, the difficulty in your preparation, so you guys can always, take my advice, okay? Thank you so much. So,
Dr. Zaib, excuse me,
yes.
the February exam will be all online, austere
sir.
exam for
No, no.
IMGs.
No. It is going to be, the both. Okay, it is going to be both.
Okay.
You can even go to this year in November. Many of my candidates, they traveled to Dubai. They traveled to the UK as well. So you will have every opportunity. Okay, Rosina. I got your the number, and I will send you text. Okay, shortly. So don't worry about that. All right. So, Samia, so if you need any kind of help, you can get in touch with me on Telegram as well. Okay, no problem. I will
Okay, thank
definitely
you.
guide you from the scratch how you are going to go about. And for coming back to your question, that how much time is required, it all depends upon your own commitments, your own the job, your own the schedule. If you are working, if you are working doctor, you are working 24/7 on call days as well. So I believe you need 4 to 5 months, okay, because it needs a lot of rehearsal. It's not like
Yeah.
this is out of the world exam. This is the same like the every exam. The difference is language. The difference is how to grab the pattern, okay, how to grab the pattern. So this is how this is what you have to, and that will come after having thorough practice, after having a thorough the kind of you can say guidance, okay. And I'm happy to guide you if you really want, or anyone of you to guide. Okay, you guys can get in touch with me. And in terms of all these books, like I said, that if you will revise all these these stations, can you just imagine that you are covering so many topics? It means, and the it's a good idea that if you practice with your the study buddy, if you find a good study buddy, good and good, well and well, good. If don't worry, practice with yourself, record yourself, listen to yourself later on, be your own critic, be your own judge, be your own teacher. Okay, improve on yourself. sometimes, what happens is that, I have recorded myself and I don't like it. So I will record it myself
Yeah.
again. I will listen to myself again.
Mm.
So sometimes, that's how we improve. That's how, we always improve. And always remember, there's always room of improvement. Okay. Although I'm a teacher,
Yeah.
but trust me, with every passing batch, with every passing, the candidates I do, the take classes. So I always learn from all of my students as well sometimes. Okay. And there is no, the kind of shame, there is no harm that if we are learning from, anyone there is. Okay. So make sure that you are taking all these, the feedbacks, all these things positively. Always think that, nobody is going to harm us. Okay. If somebody is giving us any kind of advice, so this is for our betterment. Okay. If any mentor is guiding you, this is definitely for your betterment. I am done with this exam. Okay. I have nothing to do with this exam. I'm just here to guide. I'm just here to give, my, the utmost, you can say, the sincere offer that this is how I can guide, and this is how I can teach, this is how I can give you, the best guidance with the best of my knowledge. Okay. Okay, great. So I hope you
Thank
guys
you
have
so
had
much.
good session. Okay. Thank you,
Yeah.
Ruqayya.
Thank
Thank you
you.
so much. Thank you so much. Thank you, Tripti. Thank you, Tripti. You know you are so close to my heart, and you will always be. And be like this, okay? Study, study hard, and always remember that none of the exam is easy. Okay, we have to work hard for every exam, and for every this MRCOG journey, this is a kind of competitive exam. Okay, because we have to compete with the brains all around the globe. Okay, because the pass marks are equal for every candidate there is. Okay, so remember, we have to compete with brains. Okay, I have to compete with you, I have to compete with Rahma, I have to compete with Ruqayya, I have to compete with everyone. So I don't know what your caliber is. Okay, I don't know how you the perform. I don't know how you do. So the best of the candidate is going to win is the who is prepared, who is well prepared, who hasn't left any kind of loophole, who is all the prepared to go for this exam. All right, so don't look back, don't get intimidated, don't be upset. Okay, and just prepare, give your 100%. And of course, nobody knows what will come in exam, and nobody knows what is going to be the result. So what your aim should be, what your job should be, that you have to be 100% in your own. What will be the next topic? So sweetheart, subscribe to Med Exam Expert, okay, Facebook page. So every announcement will be made over there. For me, I hope I will take another session in mid of December. So I will announce shortly, okay? So follow me on Facebook and follow Med Exam Expert page as well. So you will get all, the kind of announcements on time. All right. So see you guys. Thank you so much. Thank you so much for being here. Thank you so much, Nazia. Thank you so much, 50. Okay. All the very best to all of you. All right. And study hard. And remember, nothing is easy in this world. Okay. You have to work hard for every exam, every degree there is. All right. Okay. Thanks so much. Good night. Bye bye. Take good care of yourself.